In the United States, the leading killer of children is trauma. My partner and I should know. We're paramedics.
Each year, paramedics and emergency medical technicians respond to more than 500,000 cases of child trauma. That's a lot of banged-up kids, and it's the toughest job we face.
Over the past several years, our unit has worked closely with Children's Hospital National Medical Center to develop a pre-hospital treatment protocol which meets the unique needs of seriously injured children. We'd like to share this protocol with you.
This approach reflects the concept that children are not small adults. Children differ physiologically and emotionally and respond differently to many treatments and medications. Most children are also the center of a loving family. So when the child is injured, the family is injured and must be included in our response.
The typical trauma profile involves a 6-year-old boy weighing approximately 50 pounds. The child has sustained blunt trauma injuries in an auto accident, either as an unrestrained passenger or as a pedestrian. The most common injury sites include the head, torso, and extremities. Penetrating injuries are infrequent. Often a family member is present.
Hi, we're here to help you. Can I get where you are?
Yes.
Okay, you can stand right about here.
Okay, he's got a good airway.
Does he have any medical problems?
No, he doesn't.
Okay, well, the best
If
place to do is
possible,
right here.
we encourage a parent to remain close to the child during the assessment. We both describe our actions in a calm, positive manner.
We also get a brief description of the accident. We find that this approach reassures the family and also helps us gain the child's cooperation.
Good.
Yeah, I've got inline traction.
Okay.
Is he dead?
No, he's not dead, Mother.
He's not saying anything to me.
No, but he's not
Our
dead.
assessment begins with a primary survey to check for life-threatening injuries. The priority is A, B, C, D, E. Airway, breathing, circulation, disability, and exposure. Next, we conduct a secondary survey, which is a rapid head-to-toe exam to assess and stabilize non-life-threatening problems.
So let's get him over and then we can work on him.
We prefer 3 people or more to perform the log roll. If no trained personnel are available, extra care must be taken to ensure C-spine immobilization.
We can roll him.
Okay.
Ready? 1, 2, 3.
Although our treatment approach is similar to the adult protocol, we've modified emergency techniques to allow for the child's physical differences.
With a severely injured child, we always assume cervical spine injury. So I maintain gentle inline cervical immobilization while opening the airway with the jaw thrust. If necessary, I use the chin lift,
Okay,
but
we
I
need
always
suction.
keep the child's neck still. And I never hyperextend the neck to open the airway. With infants, you have to be especially careful because hyperextension is particularly easy.
After my partner removes visible foreign objects from the airway, I apply suction.
I never attempt a blind finger sweep because this could force an object into the child's larynx and block the airway.
Okay, we're clear.
There's a lot of difference between the anatomy of a child's upper airway and an adult's. We've learned that these differences are critical to safe and successful airway management. For example, a child's tongue is large relative to his oropharynx. If a child is comatose and lying in the supine position, his tongue could fall back and obstruct the airway. Children come in all sizes, and a child's airway path is shorter than an adult's. So selecting the correct oral airway size is especially important. You can quickly find the correct size by measuring from the corner of the child's mouth to his earlobe. When using the pediatric oral airway, we recommend direct insertion with the aid of a tongue depressor rather than the adult rotating technique. We find that the direct method protects the child's delicate anatomy from unintentional damage. You should note that the use of an esophageal obturator airway is contraindicated in children. Under a child's chin, you'll find that the submandibular tissue is especially soft and thin. Avoid putting pressure here so the depressed tissue will not push the tongue back and cause an airway obstruction. Compared to an adult, a child's trachea is short and narrow. In the severely injured child, simple edema may be the cause of airway blockage, but also suspect a small foreign object like a peanut or candy. A child's nasopharynx is narrow, delicate, and vulnerable to injury, so we always use the oral route for endotracheal intubation. When visualizing a child's epiglottis during intubation, you'll find that it's similar to an adult's. But the epiglottis of an infant has a completely different shape. We need to be able to recognize this anatomical difference to avoid accidentally intubating the infant's esophagus. Finally, a child's larynx is higher and more anterior than an adult's. During endotracheal intubation, this makes the child's larynx more difficult to see, so we always employ additional care when intubating a child. Throughout our airway procedures, we maintain manual C-spine immobilization. Once we've established a patent airway, we secure the child's cervical spine. If you don't have a child-size Philadelphia collar, you can use a roll towel, sandbags, sponges, or filled IV bags secured with tape. Never use an adult-size collar. They're too large and may obstruct the child's airway.
After opening the airway and immobilizing the cervical spine, we provide all children with 100% oxygen. Then, I evaluate the child's breathing through the quality and symmetry of breath sounds and seal any open chest wounds.
Okay, Jamie, he does have decreased lung sounds on the right side.
If I detect the absence of breath sounds, I suspect a pneumothorax. In children, this is the most common chest injury which threatens breathing. It usually occurs without rib fractures because of a child's compliant chest structure.
If my partner finds the child's respiration shallow or labored, I perform bag mask-assisted ventilation. A child-size mask is critical for effective ventilation. The adult size is too large and doesn't provide an adequate seal. You must carry a child-size mask as part of your standard equipment load. Support the mask by placing your fingers on the child's lower jaw. With this technique, you avoid pressing the soft tissue under the chin, which could obstruct the airway.
Because of a child's small blood volume, we recommend treating seemingly minor bleeding, such as scalp lacerations, with direct pressure, rather than waiting until the secondary survey. Capillary refill is the best indicator of shock in children.
Capillary refill?
Simply press and release the thumbnail.
Capillary refill.
Blood flow should return within 2 seconds or the time it takes to say capillary refill. A delay indicates shock. No capillary refill indicates severe shock. Other indicators of shock include pale, cool, mottled skin, rapid, weak pulse, decreased level of consciousness, and rapid, shallow respirations.
A child maintains blood pressure much better than an adult. This makes hypotension a late indicator of shock in children. By the time systolic pressure drops below 80, a child has experienced at least a 20% loss in blood volume and is in serious shock. Compared to an adult, a child's blood volume is small. For example, a typical 6-year-old weighing 50 pounds has a total blood volume of approximately 1,900 milliliters. This is equal to the contents of about 5 12-ounce soft drink cans. So with a blood loss of the contents of just one soft drink can, this child would be hypotensive.
I'm going to go ahead and start the IV.
Okay.
Most children in shock respond rapidly to fluid replacement. We recommend a large bore short catheter for rapid fluid infusion.
Okay, Lord Richard, you
For
got a little
infants,
stick here.
use a 22 to 20 gauge.
That's it.
For children, an 18 to 16 gauge. We found that lactated Ringer solution is the best fluid for children, but you must adjust the quantity to the child's weight.
With a blood pressure less than 80, delayed capillary refill, or other clinical signs of shock, we give 20 milliliters per kilogram of body weight IV push bolus. Then we reassess the child and repeat the bolus if signs of shock continue.
Okay, capillary refill is still delayed 3 seconds. He needs another bolus of lactated Ringers.
Okay.
Okay, but I'm going to cover him up.
For children, the best percutaneous IV access sites are the great saphenous vein at the ankle and veins located on the arm in the antecubital fossa. For a seriously injured child, you should try to establish 2 IV routes, one above and one below the diaphragm. Starting an IV on a child can be difficult and time-consuming. Don't let this procedure delay transport. Limit your attempts to 2 sticks.
Masked trousers are often used in the treatment of hypovolemic shock. But in children, they can cause potentially serious side effects. Here are some guidelines for the use of masked trousers. Apply child-sized pneumatic anti-shock trousers if the child's blood pressure drops below 80 systolic. If blood pressure drops below 60 systolic, inflate the leg compartments only. Unless the child has suffered a life-threatening pelvic hemorrhage, do not inflate the abdominal compartment. Increased abdominal pressure from the masked trousers may inhibit diaphragm movement, causing severe respiratory distress. If you have started fluid replacement, masked trousers may also contribute to pulmonary edema. Because of these potentially serious complications, we recommend caution in applying masked trousers on children.
Okay, his level is coming up, taking out the airway. He's breathing on his own. I think we ought to start a neurological assessment.
Okay.
I'm going to run some O2.
He is crying, and that is a very good sign that his level of consciousness has come up. Okay, his condition is improving.
Oh, good.
Okay.
Mother's here, Richard.
Okay.
It's okay, Richard. I want you to tell me where most of your pain is.
When we evaluate a child's neurologic disability, we consider crying a good sign of an open airway, alertness, verbal responsiveness, and awareness of pain.
Open your eyes.
Open your eyes. You're okay.
As part of our disability exam, we also check pupil size and their reaction to light.
Pupils equal and reactive.
Children lose body heat much more rapidly than adults and can quickly develop hypothermia, even in mild temperatures. Throughout our assessment, we try to limit skin exposure and keep the child as warm as possible.
Begin the assessment by opening the child's airway. Throughout airway procedures, maintain C-spine immobilization.
Provide all children with 100% oxygen and begin bag mask-assisted ventilation if necessary. Use the lower jaw to support the hands and fingers. Do not depress the soft tissue under the chin. Listen to the chest for bilateral breath sounds. Evaluate circulation. A small loss in blood volume can put a child into shock. Check capillary refill first. It's the best indicator of shock in children. Next, evaluate skin, pulse, level of consciousness, respirations, and blood pressure. Blood pressure is a late indicator of shock in children.
Evaluate disability by checking level of consciousness and pupillary response. Consider crying a good sign of an open airway and neurologic status.
Throughout the assessment, limit exposure and conserve body heat.
Time is an especially critical element in severe child trauma. Rapid preparation for transport is essential. If a child has a lower extremity fracture, we've found that inflating a masked trouser leg as an air splint is a quick and efficient splinting technique.
Okay, just hang on, little guy. We're going to get you to the hospital in just a second. Okay, the splint's on now, Richard. It ought to feel pretty good now. It shouldn't hurt as much.
Richard, we'll be going soon. Mother's here, honey. I'm right here.
There we go.
Okay, honey. Mother's right here.
Transport management becomes more complex as the severity of the trauma increases. We believe that you should always try to transport the parent with the child.
Mother's right here, Richard.
But where the parent rides is a judgment call, based on the seriousness of the child's injuries and the composure of the parent.
You get up front, and you can talk to him right through the passageway.
Okay.
During transport, we perform a secondary survey. Our main concerns are hidden external bleeding, stabilizing fractures, and a continuing reassessment of airway breathing and circulation.
Medical in the headquarters. We're on the scene with a 6-year-old white male who was struck by a car moving approximately 30 miles per hour.
We found that providing the hospital with some basic information during transit really helps the trauma team prepare for the child's arrival. At a minimum, I let the hospital know the child's age, sex, injuries, current vital signs, field treatment, and ETA.
Patient's body weight is approximately 25 to 30 kilos. You having any pain here?
Yes.
Okay. Did you know that your mom was here with you? No. Yeah, mother's here.
Richard,
Okay.
Mother's here. I won't leave you.
Okay, you've been really good.
During transit, I continually reassess the child's airway, breathing, and circulation, and immediately update the hospital with any change in status. Child trauma is a specialty. Where available, we highly recommend transporting the child to a facility which has the experience, resources, and protocol for stabilizing and resuscitating children.
Okay, let's get them in here.
Whenever possible, transport a family member with the child. During transport, perform a secondary survey. Transmit a radio report to the hospital, which includes the child's age, sex, injuries, vital signs, field treatment, and estimated time of arrival. Continually reassess the child's vital signs and radio status updates. After arriving at the medical facility, you should be prepared to follow up your radio report with a verbal briefing. Keep your remarks clear and concise, and deliver your information in ABC order, concluding with a final status update.
Now 3 seconds.
Caring for a badly injured child is an emotionally draining experience.
Really different.
I found that talking about my feelings with my partner or the hospital social worker can be a big help. As emergency care field providers, our role is critical to the survival of the injured child. But to be successful, we must combine our medical skills with an awareness that children are different and require special handling. Only then can we significantly reduce death from trauma, the #1 killer of children in the United States. You can obtain more information on child trauma through 2 other videos in this series. Pediatric Trauma, Roles of the Hospital Team, presents an overview of tasks, responsibilities, and interactions performed by physicians, nurses, technicians, and social services staff during emergency room resuscitation and stabilization.
The other videotape in this series, Pediatric Trauma, Procedures for Emergency Resuscitation, presents the treatment protocol followed by the trauma team. The video highlights equipment, medications, and procedures which differ significantly in the treatment of pediatric trauma in the emergency room.